Okay, sorry about that. We'll make a start. Well, good afternoon, everyone, and welcome to today's teaching. First of all, I wanted to, I think, just say that our thoughts and prayers and hearts are with the people of Inga province today. It's really a tragedy what's happened there, and I guess we'll find out more in the coming days and weeks. But it's really a very sad situation for the people in Inga. Um, okay, well, and hopefully that they'll in the coming days they'll get the support that they need. Today I wanted to talk about arthritis in children and really discuss the sort of basics of rheumatology. We really haven't talked about um, arthritis and rheumatology very much. And this talk will be a little different to some of the standard things you might read about rheumatology, because the types of conditions that cause joint inflammation and arthritis in children in some settings is different to what you might read in a textbook. And so I'm going to talk quite a bit about those differences and some of the less common causes of arthritis in children. But as I say, we haven't talked about arthritis very much, and I thought it would be useful to go through this some basics of rheumatology. Always useful to start with a case, and I think this case illustrates one of the clinical dilemmas that we have quite often in patients who seem steroid dependent, who have rheumatological problems or other problems such as nephrotic syndrome or lupus that are steroid dependent. This was a girl who had, you can see her hands, and you can see that she's got the hands that almost appear like an old man's hands. They're knobbled and gnarled and swollen. Now, she had 12 months of joint pains and fever, and particularly this arthropathy, this arthritis involved her hands, the small joints of her hands, almost all the small joints of her hands, her wrists and her knees bilaterally. And she was quite well controlled if she took her indomethacin and regularly, and if she was on prednisolone 20 milligrams a day. And every time we'd try to wean it down, when it got to less than 5 milligrams per day, I'd sometimes try to wean her to second daily prednisolone, and then she'd get a flare up of her arthritis. And she'd become quite Cushingoid because of the long-term steroid use. And so I think this is a dilemma that we often face, and I'm hopefully during this talk going to speak about what we can do even when there's not the more modern medications to manage such a case, because I think mostly we can manage these cases with much lower doses of steroids and alternative medications. So to go back and talk about arthritis in children, firstly, there's arthritis that's acute and there's arthritis that's chronic. And mostly today we're going to be talking about arthritis that's chronic. And in terms of acute arthritis, then we always have to think about rheumatic fever, and that can mimic some of the more chronic systemic arthritis illnesses that we will talk about today. And then septic arthritis, of course, needs to be distinguished from some form of chronic arthritis. Septic arthritis is usually bacterial in nature, but another condition is the one at the bottom, which is called transient synovitis or reactive arthritis. And that's probably the one of the most common causes of acute joint pain and swelling that we see. And that's really just the body's reaction to a virus. It's a viral arthritis or what we call transient synovitis. It usually comes and goes within 6 weeks. And so therefore it doesn't become a chronic arthritis, which is by definition lasting longer than 6 weeks. And then the main condition I want to talk about today is chronic arthritis, and especially juvenile chronic arthritis, sometimes called juvenile idiopathic arthritis, JCA or JIA. We won't talk too much about systemic lupus erythematosus, but that's part of the differential diagnosis of JCA. But it's a talk in itself. And then there's some other conditions that sometimes cause other connective tissue disorders that sometimes cause chronic arthritis in children. And I won't talk about them today, but conditions like dermatomyositis also occur in children. In tropical countries, then there are other types of conditions that can cause arthritis and mimic chronic arthritis. And I particularly want to highlight vitamin D deficiency, Rickets, less common in some parts of the world, but more common in others. And also vitamin C deficiency, Scurvy, because that can cause a condition that really mimics juvenile chronic arthritis. And I want to explain how to make that distinction. And then there's some chronic infections that can cause arthritis, but usually there's characteristic features like a certain rash, yaws, for example. And then I want to try to explain how to make that distinction between TB arthritis and other forms of septic arthritis or other forms of chronic arthritis, because TB arthritis is not very uncommon. It's not nearly as common as some forms of arthritis, but we do see it, and it's usually associated with osteomyelitis, but sometimes with a synovitis, TB synovitis, and that can affect many joints, including the hips particularly, and the knees and elbows. So they're the types of conditions I wanted to just cover today, because they're just a bit different to what you'd read in a textbook in terms of the range of different conditions that cause arthritis. Again, it's common in that are common in children. Let's just talk about juvenile chronic arthritis first. And when people have assessed the incidence and the prevalence of juvenile chronic arthritis, it seems that the prevalence is about 20 per 100,000 children. Now, that might not seem very much, but if you think about most provinces, they have 300,000 or 400,000 people, and you could therefore expect 60 to 80 children that under the age of 16 that would have juvenile chronic arthritis. So in any provincial hospital, they'll be looking after a number of children that have juvenile chronic arthritis. And if you're not looking after quite a number of children with JCA, then probably they're being missed in the community. It's more common in girls than in boys, although there are some types of juvenile chronic arthritis that are equally common in boys and girls. And the definition is that arthritis that involves one or more joints, and that arthritis meaning pain plus the other features of inflammation, so swelling, heat, tenderness on movement, and limitation on movement, and of a duration that's more than 6 weeks. And that the duration is very important, because if it's less than 6 weeks, it's quite more likely to be transient synovitis, a viral related arthropathy that just comes and goes as the viral infection clears. And to make a diagnosis of JCA, you really need to exclude other common conditions. So firstly, multifocal staph arthritis, which sometimes is mistaken for polyarticular juvenile chronic arthritis or oligoarticular, where there's more than one joint. Sometimes there's several joints involved with multifocal septic arthritis. Again, with staph arthritis or staph septic arthritis, there's usually some other features to suggest arthritis, like a pyomyositis or like a cellulitis or an empyema or a skin rash consistent with staphylococcal disease. And then rheumatic fever, which can also needs to be excluded before you arrive at a diagnosis of juvenile chronic arthritis. And then simple things like trauma. So taking the history and doing a full examination is really important, looking for the other clinical features that might point you towards these other conditions, staph septic arthritis, TB or rheumatic fever or trauma, or if it's of a very transient nature, then transient synovitis is important. But once you've excluded all those things, then the child who's got persistent arthropathy, arthritis, really probably has juvenile chronic arthritis. It's probably the most common cause. I just wanted to the X-ray I showed before is actually typical of juvenile chronic arthritis, and the characteristic feature is actually that you don't see too much on the X-ray to begin with. Sometimes you see a sort of fuzziness around the metaphysis of the bone, a little fuzziness, but not so much in the early stages. Sometimes you'll see the joint space being a little bit separated because there's more synovial fluid in the joint. And sometimes almost always the clinical feature will be that there's a joint effusion, like you can see on the right knee of this child, the right knee joint effusion. And that will be a chronic thing lasting more than 6 weeks. But I just wanted to, I've tried to draw what actually happens in juvenile chronic arthritis. This is a normal knee joint where you've got, I just go through the bony parts, the diaphysis of the bone, meaning the sort of long part of the bone. The metaphysis is the growth plate of the bone. The metaphysis is here, this line here. Then the epiphysis, surrounding the epiphysis is the cartilage. And then between the bones in the synovial joints, there's synovial fluid. And there's a synovial membrane that keeps the synovial fluid in. And this happens to be the knee joint. So you can see the patella there and sometimes some sesamoid bones within the joint. So there's the epiphysis, the metaphysis, the diaphysis, the cartilage, and the synovial membrane. These are all important things that we should know about. It's not just orthopedic surgeons should know about it, pediatricians should know about it too. And I just wanted to show in the other diagram is what happens in juvenile chronic arthritis. And you can see that in JCA, the cartilage over time thins down and the joint space becomes much more narrowed as there's a thickening of the synovial membrane, a loss of synovial fluid, a loss of the cartilage. And so the joint space that you see on X-ray becomes quite narrow. And sometimes if it's a very damaged joint, then it looks like bone on bone. And because normally the normal appearance of a joint should be that the bone shouldn't be touching the bone, because in between there's cartilage and there's synovial fluid. But here you can see that the bone is much closer to the bone. The bone of the femur is much closer to the bone of the tibia. And that's partly because there's a loss of cartilage and a loss of synovial fluid. And because of the inflammation, the synovial membrane that keeps the synovial fluid in becomes quite thickened and harder. And that's why you get joint stiffness and limitation of movement. And because of inflammation, you get bony overgrowth of the epiphysis. So the epiphysis becomes a bit more enlarged. And so instead of the epiphysis being, relatively narrow, it becomes a more enlarged sort of overgrown bone. They're the changes of juvenile chronic arthritis where there hasn't been early treatment, I would say. This is an X-ray of a child who he was about 8 or 9-year-old boy who had juvenile chronic arthritis, and he'd been immobile for almost 12 months, and he had very severe arthritis. And I want you to be able to see the changes. Remember, I said that there shouldn't be bone on bone, but you can see here that his distal femur, the distal femoral epiphysis, almost touches the tibial epiphysis. You can see that the femoral epiphysis is quite overgrown. It looks more enlarged than what it normally is. And it's also osteopenic. There's not the normal appearance of the bone. And so because of chronic arthritis and because of immobility, you get osteopenia. And so therefore he's lost almost all the cartilage in his joints, and his epiphyses and metaphysis and diaphysis have become quite osteopenic because of mostly disuse osteopenia, which we sometimes see. So they're the features of a child who's got very almost like burnt out juvenile chronic arthritis. We hope to get children diagnosed at a time when their X-rays don't look too abnormal, and then treat them so they don't end up with what is effectively secondary osteoarthritis on a background of a child who's got juvenile chronic arthritis. Okay. But when you think about JCA, there are differences in the types of JCA. The first one is, and they differ in the number of joints involved, and they differ in what joints are involved, and they differ in the age of onset, although there's a lot of overlap. But one of the most common types is oligoarticular arthritis. Oligo means few. It doesn't mean one, it means few. And if you've got up to 4 joints involved and no systemic features, then that's called oligoarticular arthritis. If you've got more than 4 joints involved, so 5 or more joints involved, then you've got a form of polyarticular arthritis. So the girl that I showed you at the start, the 4-year-old girl, she clearly had polyarticular juvenile chronic arthritis because all the small joints of her hands were involved, and her knees and her wrists. So multiple joints involved. When you look at the small joints of the hands, you often see arthritis in the metacarpophalangeal joints and the interphalangeal joints, as she had, and they're all, you need to add them up to find the number of joints involved. There are a couple of types of polyarticular arthritis, and you can't always make the distinction between the two because sometimes you don't have rheumatoid factor, but there is a form that's occurs in younger children that's rheumatoid factor negative, and a form that occurs mostly in older children that's rheumatoid factor positive, and they behave a little differently. The form of polyarticular arthritis in adolescents looks a bit more like rheumatoid arthritis in adults, and the form of polyarticular arthritis in younger children looks a bit more like oligoarticular arthritis, oligoarticular JCA in younger children. Then there's a form of JCA that involves the spine, and it particularly it causes a spondylitis. And as you probably know, that those children are more likely to be HLA-B27 positive. That's the characteristic feature, and that there is a link between those types of arthritis and chronic inflammatory bowel disease. The main thing to know is that they get sacroiliac and spine involvement, and they're usually adolescents, older children. And then there's another form of JCA called psoriatic arthritis, where there's the rash of psoriasis. This is relatively uncommon in children, but it does occur, and they're more likely to have what's called dactylitis. And dactylitis is an arthritis of the small joints of the hands, particularly the fingers, and they get a thickening of the fingers. And sausage-shaped fingers it's often described as. That's psoriatic arthritis, but only when you've got the psoriatic rash. I'll show you a picture of those in a moment. And then the last form of juvenile chronic arthritis is systemic onset JCA, and those children they're quite difficult to diagnose, but they often present with an acute or chronic inflammatory condition, a hyperinflammatory condition with fever, prolonged fever and arthritis, and sometimes a skin rash, a characteristic, well, not characteristic, but an erythematous skin rash. They sometimes have inflammation of their eyes, what's called uveitis. Not always, though. If they don't have uveitis and they don't have much in the way of arthritis, or even if they do that, it's hard to make the distinction from systemic onset JCA to other forms of inflammatory conditions like SLE, or like rheumatic fever can often look like that. So there's a number of differential diagnoses of systemic onset JCA. Even the post-inflammatory condition of COVID, the COVID virus, we were seeing some of those children look like they had systemic onset JCA. The arthritis is a key feature, but they can also present with just generalized inflammation. This is dactylitis, where you can see the sausage-shaped fingers that this child has with an inflammation of the fingers. It's not always psoriatic arthritis. Certainly TB can give you a dactylitis too, and we see that quite a bit. This is the psoriatic rash. It's not, you can see the sort of plaques of thickening of the skin. This is like psoriasis in adults, but again, much less common than the other forms of arthritis, but I just thought I'd show you the rash. I mentioned before that if children don't get treatment for JCA, then they can end up having quite significant skeletal and joint deformities, and that just occurs because of the erosive nature of joint arthritis, and sometimes with secondary osteoarthritis, where you get osteopenia and cartilage erosion and often valgus deformities of the knees And sometimes if you've got a single joint involved, like a knee, then you'll get leg length discrepancy because there's a lack of growth of the joint, lack of growth of the bone. And sometimes children get joint deformities because of osteopenia that can relate to disuse atrophy, or it can relate to steroids. Now we're seeing that much less these days when most children are not steroid dependent, but whenever you give like chronic steroids to patients, they're at risk of osteopenia, and we need to think of that. We hopefully these days, not many children reach that stage if they are diagnosed and treated early. I mentioned before systemic onset JCA, and that's quite important. It's about 10% of all juvenile chronic arthritis. And the way to diagnose this is to think about it in a child who's got a chronic inflammatory, a prolonged fever. And these children generally have a fever for more than 2 weeks. It's sometimes they're all the time, but sometimes it's intermittent as well. It may come and go each day, but it's usually present, a high fever above 38 degrees. They have arthritis. It's usually symmetrical and it's usually polyarticular. So not just a single joint involved, which might make you think more of septic arthritis. And sometimes it's a bit migratory. So you then think of acute rheumatic fever. They have a rash that's a bit characteristic. It's called a salmon pink rash. It doesn't look like psoriatic arthritis, and it looks a bit like sometimes like a group A streptococcal infection, but it can then be a bit hard to make the distinction. Some of these children have an inflammatory polyserositis, so they might have a pericardial effusion or a pleural effusion, and that can be challenging to make a distinction between that and, say, tuberculosis. But we have seen some children with polyserositis who clearly have a sort of chronic inflammatory condition, whether it's JCA or some other systemic inflammatory connective tissue disorder. And I guess you need to sort of have that in the differential diagnosis when you're thinking about, could this be TB or could it be some other chronic inflammatory condition or rheumatic fever? You just need to sort of consider systemic onset JCA. Sometimes these children have uveitis, the inflammation of the eyes, the iris of the eye. It's if you're uncertain, then it's good to. Sometimes you can see it with just a torch, and sometimes it needs a slit lamp to see the uveitis. But ophthalmologists can usually diagnose this. Sometimes children with systemic onset JCA have hepatosplenomegaly, and again, this can make it somewhat hard to make a distinction between, say, TB and other systemic conditions like leukemia or systemic lupus erythematosus, but just to know that JCA can present with hepatosplenomegaly as well. It can look like sepsis. These children have high inflammatory markers, like they have a neutrophilia and a high erythrocyte sedimentation rate and a high C-reactive protein, if you can do those things. They often have a high ferritin, so they're as an acute inflammatory response. Their ferritin level is very high, but still they're often iron deficient. So there are other markers on their blood film show iron deficiency with microcytic hypochromic anemia, often a low hemoglobin. Their MCV will be low, and often their platelets will be high as a marker of inflammation, just like their ferritin being high, if you can measure their ferritin. That's just a marker of inflammation and iron deficiency. Usually the iron deficiency is because of the iron gets sequestered within the reticular endothelial system in chronic inflammation, like in chronic JCA. It occurs in males and females equally, and it's a bit more common actually in Southeast Asia, in some parts of the world, than it is in others. So JCA, systemic onset JCA seems more common in Southeast Asia. As I said, you may have to make the distinction between systemic onset JCA and other forms of chronic inflammation, like infections, sepsis, chronic sepsis, or typhoid, rheumatic fever, even malaria, leukemia, rheumatic fever, inflammatory bowel disease, which can sometimes look a bit the same, have other features, but not the arthritis usually, and tuberculosis, the great mimicker, and drug reactions even, because many of these children, by the time you've seen them, have been put on lots of drugs, and sometimes that can cause some sort of eosinophilic arthritis or something like that, high fever. So just consider always a broad differential diagnosis in these patients. And the way to arrive at a diagnosis of systemic onset JCA is to have thought of all these other conditions and to be excluding them when you can. I want to just talk about the management of JCA now. And firstly, the aims of the management are fairly simple. You've got to manage their pain first. The children's pain has to be managed so that they can start rehabilitating, and they need some rest to start with, but fairly soon after they need mobilization of once the pain is controlled, then they need mobilization of the joints. So you get back the joint movement and a full range of movement. And sometimes when you get to see these children, they've got limitation of movement that's secondary to disuse. If they're not moving their limbs, if they're not putting their joints through a full range of movement, they'll get contractures. The boy I showed you with the severe osteopenia, he had severe contractures of all his limbs, and it took 6 months for him to get the joint movement back. But first of all, you control the pain, you achieve normal function if you can, you minimize ongoing joint damage, and you minimize side effects of the drugs that you're using. And everything that we do is based around these 4 aims. All right, so all the medications, the physiotherapy, everything, the lifestyle things, nutrition, are all based around these 4 aims. There's several tiers of management of JCA, and I want to go back a bit to that first case I mentioned of the girl who was the 4-year-old girl who was chronically steroid dependent, and talk about an alternative, because I think mostly these days we have children on non-steroidal anti-inflammatory drugs like ibuprofen or indomethacin or aspirin, and we then add steroids. And for most forms of JCA, you're better off not using high-dose steroids for all the reasons I mentioned. This child had been on steroids for about 12 months. It was quite Cushingoid. That leads to osteopenia. That leads to other adverse effects. And so you're better off, if you can, to use methotrexate. And the dose is 10 milligrams per meter squared subcutaneously, or sometimes it's given intramuscularly or orally each week for 4 weeks. And that's not a chemotherapeutic dose of methotrexate. It generally doesn't cause major immune suppression. It will cause some immune suppression, but not major neutropenia. And then if you've had the child while you're waiting to start methotrexate, if you've had the child on steroids, then try to taper the steroids off over a few weeks. When you're using methotrexate, you need to use also folic acid, because methotrexate is a folinic acid inhibitor, and that can help to reduce some of the other effects of methotrexate, like the bone marrow suppression. Usually when we're using this dose of methotrexate just once a week, then children don't get too immune suppressed, but you still should use cotrimoxazole prophylaxis and isoniazid prophylaxis, INH prophylaxis, to prevent, reduce the risk of TB, and cotrimoxazole prophylaxis to reduce the risk of pneumocystis pneumonia and also other bacterial infections. Usually if you do that and you monitor their full blood examination about once every 3 months, sometimes once a month to start with, then usually the patients are well managed. I generally give methotrexate for 4 weeks to start with, and then depending on the response, usually you get a response within 4 weeks, and then you can hold it for a while and then reintroduce it if you get a flare up on non-steroidal anti-inflammatory drugs. Sometimes children need to stay on a dose of methotrexate longer term, and that can be done safely as well. safer in many ways than using long-term steroids. For children who've got oligoarticular arthritis of the large joints, then intra-articular corticosteroids can be useful. And it's not that hard to do if a child's got a large effusion and very painful joints, but it needs to be done a bit like we've discussed other things, with some procedural sedation under very sterile conditions, of course, so that you don't introduce infection into the joints. And ideally with, you can use dexamethasone, but triamcinolone is a better steroid. That's the ideal steroid to use within joints. You can use other steroids as well. Dexamethasone is okay. But of course, if you've got polyarticular arthritis like the girl I showed you at the start, you can't inject into the small joints of the hands. I wouldn't try that, but it's not that hard to inject into knees and get a good outcome for those children in those large joints. I tend not to inject into hips because it's much harder to do. You need to do it under ultrasound guidance, but I think it's good to learn how to do interarticular corticosteroid injections and how to do it in a very sterile way and with adequate procedural sedation so the child can tolerate that well. I think it's good to limit the use of systemic corticosteroids like oral prednisolone to only third line. If you don't have methotrexate while you're waiting for methotrexate to become available, or if a child's got systemic onset JCA, that's first line treatment. So non-steroidals and prednisolone. For systemic onset JCA, always use prednisolone to start with, not methotrexate. And then, but that of course applies to children. Only about 10% of cases of JCA. The normal, not normal, but the oligoarticular and polyarticular arthritis, you're better off using methotrexate to begin with if you can. These days, there's some more immune therapies that are used for juvenile chronic arthritis. I won't go into them today. There's some an agent called anakinra, which is often used, and infliximab, different immune therapies that are rarely available. They act on interleukin-1 and interleukin-6 particularly, and they're the cytokines that are most implicated in the inflammation related to JCA. But again, we won't talk about that today. Methotrexate is a good second-line therapy when non-steroidals fail, and in combination sometimes with steroids. Physiotherapy is important, and again, once you've controlled the pain, then get on with mobilization and that sort of thing, and teach children their own exercises so they don't have to only do physiotherapy when they see the physiotherapist, but teach them the exercises they can do each day that will help them mobilize and get better. Every child with, I mentioned before, but if they are on methotrexate, they need 3 monthly review, even monthly review to start with, and a full blood count to make sure that they're not getting neutropenic or not being too lymphopenic. They need to make sure they're taking their cotrimoxazole and taking their isoniazid. They need to be screened for TB at the start before you start them on methotrexate. And they need at least 12 monthly ophthalmology reviews. So I always have them reviewed by an ophthalmologist at the start, and then at least every 12 months. And that's to look for this condition. Again, sometimes you can see it with just a torch, a flashlight, or you can see this. This is the iris, and you can see these white plaques that occur in the iris. That's uveitis or iridocyclitis. And it's an inflammation of the eyes, of the iris of the eyes, that occurs in some children who've got JCA. And these children, for these children, you use topical corticosteroid drops, and sometimes we use methotrexate. Most of these patients are on methotrexate or some other disease-modifying agent. Okay. That's all I want to say about JCA. I wanted to talk about some of the other, I would say, differential diagnoses. When we're thinking about a child who appears to have arthritis or swollen joints, we always need to think about some other conditions that might be treatable and need to be excluded. And one of them is Rickets. Now, Rickets has, many different characteristics to JCA, but it does cause joint swelling. And it's not so much a condition of joint inflammation like JCA, but it's more a condition of joint growth. And I wanted to just say a bit about Rickets and try to explain why Rickets occurs. I mean, Rickets occurs because of when the bone is growing at the growth plate, which is between the metaphysis and the epiphysis. The growth plate is there. The bone is growing at that point. Then the body has to lay down calcium and phosphate in between the osteoblasts for bones to be strong and hard. And if you don't have calcium because you don't have enough vitamin D, so therefore the body can't absorb enough calcium, then a child will develop rickets. And that can lead to joint swelling, and the bones become soft and bend, so you get valgus or varus deformity of the joints. And it can look a bit like chronic arthritis. And the main reason to mention it here is to again emphasize that pediatricians have to know about the different parts of the bones, because different diseases affect different parts of the bones, and rickets affects the growth plate at the metaphysis, the growth plate where the bone is growing. When you look on an X-ray of a child with rickets, then remember he said this is the metaphysis, this area here, this is the growth plate, and you can see how irregular it is, how fuzzy the metaphysis is. The epiphysis looks reasonably normal, but the metaphysis, where the growth plate is, looks very fuzzy. And these children often have swollen joints and could be mistaken for having arthritis, but they've got rickets. The treatment is much simpler than using, again, to make that distinction, so you don't be using anti-inflammatory drugs or non-steroidals or methotrexate in these patients. You simply have to replace the vitamin D that they are missing, the calcium and the phosphate, usually with improvements in their diet. But vitamin D, the dose is 2,000 units per day for 3 months. That's how you treat rickets, not per kilo, but every child, regardless of their age, give 2,000 units, international units. Usually they come in tablets or capsules of 1,000 units, so you have to give 2 of them per day for 3 months. And calcium, again, they usually come as tablets of 500 milligrams. I usually add the dietary supplement, but also in conjunction with higher calcium rich foods that also have phosphate in them. So milk and cheese, dairy products, particularly beans, have calcium and phosphate. Some nuts and seeds and green leafy vegetables. So a balanced diet will contain enough. But for children who've got rickets, then it's important to have some sort of sunlight exposure because that activates activated vitamin D. And also, if they have intractable rickets, then make sure you investigate them for renal tubular acidosis, because we sometimes see renal rickets as being a bit more common in PNG because of renal tubular acidosis. These children also need weight-bearing activities, because just like children with JCA, if you bear weight on the joints, that helps bone growth. It helps healthy bone growth, and it helps laying down of new bone. So any weight-bearing activities, just normal play and walking, running, that is essential for building strong bones. And that's why children who've got cerebral palsy who are not weight-bearing or got neurodevelopmental problems that are more wheelchair bound or not weight bearing, they'll develop osteopenia because of the lack of weight bearing on their joints. And the last thing is, there are some children that are a bit more prone to rickets than others. And I mentioned children who've got RTA, renal tubular acidosis, but also consider children who've got who are on anticonvulsant medications for epilepsy, because they can inhibit vitamin D absorption in the gastrointestinal tract. And those children often get rickets. So if you've got a child who's on phenytoin or phenobarbital, particularly phenytoin, you should give them vitamin D supplementation, or they'll get osteopenia and may develop rickets. I showed you the x-rays of a child with rickets before, and I want you to look at these x-rays because they look a bit like rickets. And again, it's obviously a problem at the growth plate, at the metaphysis of bone. And this is a slightly different problem. And this is a child, he was about 4, and he came in with swollen knee joints and this a fixed flexion deformity of both knee joints. He also had some bleeding of his gums. And I think this is an important condition, one, because you need to think about it to diagnose it, 2, because it's got some important differential diagnoses, like leukemia particularly, but 3, you can make the distinction by the clinical features and by the x-ray features and by a response to treatment. And this boy had this metaphyseal roughening of the metaphysis, and as you can see, and so it could have been rickets, it could have been potentially even leukemia, although the x-ray appearance is a bit different. But what it was, he had loose teeth and he had gum bleeding, and this is scurvy. And it's more, the x-ray appearance is more characteristic of scurvy than it is of leukemia, and it's a bit more characteristic of scurvy than it is of vitamin D deficiency, although the overlap is quite strong, I think, between rickets and scurvy. A bit different, but a strong overlap. This is the giveaway, if you like, is gum bleeding, but that could also occur with leukemia. So when you're faced with a child like that, always think of these 3 different conditions as part of the differential. Scurvy causes joint effusions. So the reason why they have quite swollen joints. And if you can see here, this is a boy who had rickets, scurvy, and you can see how the epiphyses are very much separated. And that's because there's a lot of synovial fluid, a big joint effusion, and you can see the growth plate of bone is very rough and irregular. And that's very typical of scurvy. They often have gum bleeding, they may lose their teeth, and they're susceptible to hemorrhage. They may have petechial hemorrhages as well, as this boy did. So if you see that constellation of clinical features, then think of scurvy. You should do x-rays of their wrists and their knees, the sternal ends of their ribs as well, because looking for ricket-like abnormalities. But children with scurvy also can have like a rickety rosary abnormality of the sternal ends of their ribs. What's happening at the metaphysis, at the growing part of the bone, is hemorrhage usually, and these are areas of hemorrhage within the bone, and that leads to replacement with granulation tissue and further hemorrhage, and that's why their joints are very painful, and they have a large joint effusion. So they can look a lot like kids with JCA, but you have to take a very good nutritional history to make the diagnosis of scurvy. The good thing is that within a few days of starting treatment, these children get better. And so you just need to put them on vitamin C, 100 milligrams 8 hourly for 10 days. So you can buy that at the commercial pharmacies, or maybe the pharmacy, the hospital pharmacy has it. But it's well worth thinking about scurvy in children and taking a really good dietary history. I wanted to show the distinction between scurvy and vitamin D deficiency and leukemia, because sometimes as I say, they overlap in the clinical presentation a bit. In leukemia, the features are not so much a rough, irregular metaphysis, but what is seen as lucent meaning more black. So you've got opaque and lucent metaphyseal bands. So the metaphysis is not irregular and rough, but it's a lucency, a lucent band at the metaphysis, quite somewhat different to scurvy. as I say, they can be difficult to make that distinction. But this was a child who had leukemia and bone pain. And we know that bone pain is a common characteristic of leukemia. But when you do the x-rays, you'll sometimes see these lucent metaphyseal bands at the area of the metaphysis, at the area at the end of the long bones. Just important to make that distinction. Almost lastly, I just wanted to cover yaws and syphilis, treponemal infections that can also give you joint swelling and effusions and abnormalities on X-rays. And I think you can see perhaps you can see on the chest X-ray that this was what alerted us to this patient. The humerus, you can see this double line of the cortex, the so-called tram tracking double line of the long bone cortex, and it almost, well, it looks like this child might have bilateral osteomyelitis of the humerus. And whenever you see this osteomyelitis, the appearance of the double, the periosteal reaction occurring in multiple bones, then think of syphilis or yaws. And this is again the radius and ulna of a child who had untreated syphilis, and you can see the double line of the cortex, the translucency, and some again sort of cystic changes within the bones. But the characteristic is this double line in these bones. Some syphilis is a rare cause of arthritis, but yaws can sometimes cause arthritis. Again, it sometimes causes dactylitis, a bit like I showed you with psoriasis, and a bit like with tuberculous arthritis. Again, the features, usually you make the diagnosis of yaws based on the rash, don't you? On the ulcers, the skin ulcers that occur. And that's the primary way to make the diagnosis, not so much the arthritis. But when you see arthritis in yaws, then think about when you see arthritis and a skin rash with ulceration, then think about yaws as being the diagnosis. The rashes are, I mean, you probably, to talk about yaws is another topic, but it can start with a papilloma, and then it becomes ulcerated and often granulated around the edge. It's usually a very well demarcated rash, and often the children are undernourished and they have joint pains as well. These children respond very well to benzathine penicillin intramuscularly or azithromycin if you don't have benzathine penicillin, and they respond very well. And lastly, the last thing I wanted to just cover is, I'm not going to talk too much about TB, but just to talk about the clinical and radiographic features of tuberculous arthritis. And bone and joint disease in TB is obviously very common, and we see lots of Pott's disease and we see some TB osteomyelitis, but TB arthritis is often underdiagnosed, I would say. But TB arthritis makes up about 10% of extrapulmonary TB. And usually these patients have TB in other locations. They might have a spondylitis with Pott's disease or osteomyelitis, but always think about if a child's got immobile or got joint pains, then think maybe they've got TB arthritis. It occurs most commonly in the spine, in the hips, in the knees, sometimes in the elbows, and sometimes in the hands, causing a dactylitis. And TB arthritis starts in the metaphysis, that area close to the growth plate of bone, and then it can spread. The inflammation spreads into the joint space, so you get material TB inflammatory fluid, like sometimes caseating material in the joint space itself. The characteristic feature is that it looks quite different from some of the other conditions I've shown you. It looks different to JCA on X-rays. It looks different to scurvy and vitamin D deficient rickets, and looks different to leukemia. And that is the typical characteristic, not always, but the typical characteristic is cystic change. I'll just move this over here. And I think you can see these cystic changes in the bones. And that's quite typical of TB. And remember, it's in the metaphysis of the bone. The rest of the bone, the diaphysis, is usually fairly spared, and there's close to the end of the long bones, you'll see these cysts. And that, if you see that, then think of, could this be tuberculosis? Remember, it looks quite different to the other conditions I've mentioned, Rickets, Scurvy, JCA. Look for cysts. And if so, not all TB arthritis gives you cysts. There are some that give other changes, but that's more than half of all will be characterized by cysts. The differential diagnosis of cystic change in bones includes things like benign bone cysts and eosinophilic granulomas, but if you see it and it fits with the other features, then sometimes we can do a synovial biopsy, like aspirating the synovial fluid and doing gene expert on that fluid, or there'll be other features of TB elsewhere, or a very positive, strongly positive MAN2 test, or something that'll give you a clue that this could be TB arthritis. Here's just another child who had TB arthritis of the hip. Again, a common location for TB arthritis. And what you can see is the cystic change in the metaphysis of the femur. So this is the epiphysis. This is the metaphysis here in the femoral head, and you can see these cysts there. And again, this is quite characteristic of TB. So again, if you see those changes, then think about, could this be TB arthritis? All right. So we've covered a lot of ground today. And again, many of these things I've talked about involve conditions that you won't easily find in a rheumatology textbook, but I've tried to talk about the important treatable causes of arthritis in children, especially chronic arthritis. There are many causes, but JCA involves an exclusion of other causes. You just have to think about the other things and exclude them based on a good history and a good examination, especially a nutritional history and a good examination. It's not, pediatricians need to know how to do proper joint examinations and take a proper history of pain in joints particularly. I haven't gone too much into those basic aspects today, but we really should get good at the practical aspects of taking a good history of joint pain. I haven't mentioned many sophisticated tests today. I mentioned an ESR and a rheumatoid factor, and sometimes you'll have them and sometimes you won't, but you actually can mostly make the diagnosis based on those clinical features and a full blood examination to rule out things like leukemia and to look for other features of bacterial infection or chronic inflammation. So a full blood examination is probably, if that's all you have, then you can make most of these diagnoses based on history and examination and thinking through carefully what the differential diagnosis is. I've talked a bit about how you need to classify the type of arthritis, like make that distinction, and the type of JCA, because that can lead you to the type of treatment that you give. Non-steroidals are the first line, so ibuprofen or naproxen or indomethacin, aspirin. And the second line treatment should be ideally methotrexate if you've got it, if you've diagnosed polyarticular or chronic severe oligoarticular JCA. And steroid should only be the third line unless it's systemic onset JCA with a hyperinflammatory response. And remember that the simple goals of treatment: control pain, enable mobilization and normal function, and limiting side effects and improving quality of life. Those things are important. And remember the non-pharmacological therapies, the mobilization and physiotherapy, that's so important. So that's all I wanted to say about arthritis today. I think we've covered a lot of ground, and I'm happy to answer any questions that you might have. I'm going to stop sharing my screen now, and if anyone's got any questions, please feel free to ask. I'll just pause the recording now. Yeah.